Okay, I can see we've got quite a few people now, so we'll make a start because we've got quite a bit to get through. So, good evening, and thank you very much for joining us for this session on understanding treatment for incurable pancreatic cancer. My name's Simon, and I'm one of the specialist nurses here at Pancreatic Cancer UK. I joined the charity 2 years ago as one of the specialist nurses. Prior to that, I've been a nurse for 26 years. 15 of those working as a clinical nurse specialist in palliative care, and that was in community and also a hospice. Before that, community nurse and also specialist surgery. So that's a very brief stop on what I've been doing. This evening, we're going to be talking about what are chemotherapy and radiotherapy and how they're used to treat pancreatic cancer. What side effects can I expect with these treatments? How can I stay as well as possible before, during, and after my treatment? What are some useful questions I should ask my healthcare team about my treatment? And where can I get further support? We'll be welcoming my colleague Lee Booth to talk about this with you this evening, and I'll introduce her shortly. Before we begin, we wanted to acknowledge that there may be interest in understanding more about new treatments and clinical trials, especially with news of the work around daraxonrasib featured in the news recently. This evening's session will focus on established treatments of chemotherapy and radiotherapy, though we'll be sharing our response to this work in the chat shortly. And there'll be a link to the trial finder where you can find out more, where you can find out more about clinical trials. And this will be shared with you later in the week via email as well. If time allows this evening, we may be able to answer any questions you have towards the end of the session. And you can always call us on the support line if you'd like to discuss new treatments with myself and any of the specialist nurses. So before I hand over to Lee, I'm just going to very quickly go through with you about daraxonrasib. As you may have seen in the media, there's been a lot of excitement around the results of a trial in the US for a potential new treatment for pancreatic cancer. And the drug used in the trial is a KRAS inhibitor called daraxonrasib. And before we cover the current treatment options, we just thought we'd explain a little bit about what we understand so far about this treatment. So, what is KRAS? In basic terms, KRAS is a gene involved in regulating cell growth. Under normal conditions, KRAS acts like a molecular switch. So when it's off, it's inactive. When it's on, it's active. In pancreatic cancer, KRAS becomes permanently stuck in the on position due to mutations. So like a jammed accelerator pedal, and this can lead to the formation of tumours or cancer. And KRAS mutations are present in over 90% of cases in pancreatic adenocarcinoma. So what's a mutation? Germline mutations are changes to your DNA that you inherit from your mother and your father, whereas somatic mutations are changes to DNA that happen to an individual over the course of their lifetime for various reasons and are not inherited. KRAS mutations are somatic changes, so you don't inherit them or pass them on. So what are KRAS inhibitors? So KRAS inhibitors directly block the activity of KRAS genes, interrupting the signals that tell cancer cells to grow. In effect, trying to switch off the faulty gene, causing the abnormal KRAS signal and growth of cells. And these treatments are a form of targeted therapy. So is this treatment available to me? The issue at the moment is the only current trial available in the UK for daraxonrasib is Resolute 304. And that's only for those who've had surgery followed by chemotherapy and are cancer-free. This picture may change in the future with other trials opening for different stages of the disease, but as yet, none have been released. And currently, daraxonrasib is not approved for use in the UK, either on the NHS or via private care, but again, this may change. And we have a blog which covers this in more detail, explaining what we currently understand, and that blog will be updated regularly. So we'd encourage you to check on that, and you can also speak to us on the support line if you need more information. Right, so that was a whistle-stop tour. I'm going to hand you over to Lee now, and she can share a bit about yourself and then introduce you to the session, and I'll catch up with you later.
Thank you, Simon. Good evening and welcome to you all. Thank you so much for joining us tonight. My name's Lee Booth. I'm one of the 7 specialist nurses who works on the support line here at Pancreatic Cancer UK. I joined the nursing team here at the charity almost 2 years ago. My role prior to this was as a HPB CNS, so a liver, pancreas and biliary clinical nurse specialist at a large teaching hospital in the West Midlands. I've also been a research nurse within the speciality of liver and pancreatic cancer, and I started my nursing career as a chemotherapy nurse 15 years ago on an inpatient ward for all ages and cancer types, which included teenagers and young adults. But that's more than enough about me. Let's concentrate now on treatments for incurable pancreatic cancer and keeping well. Throughout, I'll be sharing my thoughts on useful things you might want to discuss with the team involved in your care. But tonight is also an opportunity for you to share your experience and top tips with each other. So please do pop these in the chat like Simon mentioned earlier. And as he did also mention, we'll have time towards the end of the webinar tonight for questions and answers. So please do keep adding these as we go into the Q&A box. I want to first spend a couple of minutes chatting over what happens in the lead up to you being offered or discussing treatment options and how the team and yourselves might come to the decision of what treatment will be the best option for you. There's quite a few pieces of information that are needed to come together before treatment can be planned by your oncology team. This includes things like scans, blood and biopsy results, and how well you are feeling. This information is brought together and discussed at something called a multidisciplinary team meeting, which you'll often hear being called an MDT. These are usually based at a hospital where the surgery takes place or a specialist centre, but your local hospital, if appropriate, will feed into these meetings as they know you best. As with everything, weighing up the benefits and burdens of treatment is essential, as this allows you to make the best choice about what is the right thing for you right now. Remember, this is your treatment. It's happening to you, so it's important that you and your family feel part of the decision-making process. So, what is chemotherapy and how is it used to treat pancreatic cancer? Chemotherapy, or chemo as it's often shortened down to, is one word to describe many different drugs. It's usually given as an intravenous infusion, but sometimes chemo might be in tablet form as well. And its job is to kill cancer cells and to control the cancer. We want treatment to be systemic, and what I mean by this is that we want to give chemo that kills pancreatic cancer cells that are anywhere in the body. This is why it's used to treat both locally advanced and metastatic pancreatic cancer. We can't talk about chemotherapy without mentioning the drugs that are commonly used to treat pancreatic cancer, so that you can be familiar with the words that you might hear in your consultations and perhaps want to talk to your family and friends about. It can be confusing, all the different names of the chemotherapy drugs, and often we as healthcare professionals love to abbreviate them, which really doesn't help at times. So you might hear things like nab-paclitaxel being called by its brand name Abraxane, or gemcitabine and capecitabine being called GemCap. I thought mentioning this might bring into focus the medical jargon and give some clarity. You can see that we use different drugs in different combinations, and we call these combinations regimens. One full dose of treatment is called a cycle. Your team will give you information about your treatment option, and you'll need all of this before you're able to make an informed choice about what the best option is for you. We mentioned previously the need to weigh up the benefits and burdens of treatment. And when looking more closely at chemotherapy, the potential benefits are that it can control the cancer, can improve and maintain your quality of life, and it extends life. But chemo is really a blunt instrument. And in truth, we don't know exactly how chemo might be for people. So information about its burdens must be given before starting. I would expect prior to starting chemotherapy that you be given written information about the regimens, so the types of drugs that will be used, their names, and how they are given. It's also important to discuss things like how many hospital visits you might have with each cycle for bloods, checkups, and treatment itself. Most importantly, you need to understand how chemo might make you feel, its potential side effects, and how to manage these. I'm not going to go into too much detail on this now, as I'll cover that a little later on in the keeping and staying well section. We do have lots of information on our website about chemotherapy and side effects, which you can take a look at as and when you feel you need or want to. Sometimes hard to make sense of what all this means for you. And of course, you can always give us a call on the support line with any questions you might have. So we've touched a bit on chemotherapy. Now let's look at radiotherapy. Radiotherapy is a treatment using radiation to destroy the cancer cells, and it's given either on its own or together with chemotherapy to treat locally advanced and advanced pancreatic cancer. There are two main types of radiotherapy: external beam radiotherapy, which includes IMRT, and there's a lot of abbreviations here, so I will explain a little bit, but any questions, pop them in the Q&A. Intensity modulated radiotherapy, it's IMRT, that uses radiation beams arranged at different angles so the tumour gets the maximum amount of radiation. Or there's VMAT, which is volumetric modulated arc therapy, which is one continuous beam delivering radiotherapy as it moves around your body. External beam radiotherapy is often given with oral chemotherapy called capecitabine, which is a tablet that you take at home. This makes cancer cells more sensitive to the treatment, so helps it to work, making it hopefully more effective. And then the stereotactic ablative body radiotherapy, which is a bit of a mouthful and with a lisp even harder to say. So this is often called SABR or SBRT or CyberKnife, as you may have heard it. SBRT stands for stereotactic body radiotherapy. SABR is the most recent type of precise radiotherapy, and it delivers higher doses of radiation in a shorter time over fewer sessions than the external beam radiotherapy types. It's typical to have at least 3 months chemotherapy before SABR, but there's none during this type of treatment. I think it's important to say that the effectiveness of both these treatments are very similar. SABR and SBRT, or any of the names, deliver higher doses of radiation in a shorter time, which reduces the number of days people must go to hospital, and the more precise field of treatment can potentially reduce side effects. External beam radiotherapy is widely available. However, SABR, SBRT is only available in some specialist hospitals in the UK. So, benefits. Benefits of radiotherapy. Treatment can be quick. For external beam radiotherapy, it could be as quick as 50 minutes a day, whereas SABR SBRT takes a little bit longer, and sometimes it's 30 minutes or more, but this isn't every day. Your radiotherapy will be as an outpatient. There's often fewer side effects than chemotherapy. It treats the cancer. It helps with symptoms. And the burdens. Ooh, a few clicks later. There can be side effects such as tiredness, sickness, and diarrhea, but they tend to be mild when experienced. If having chemotherapy combined with radiotherapy, the side effects may be more prominent. Can be daily travel to and from the hospital, which might add in increased tiredness, especially with the more treatment sessions you have. Not everyone can have radiotherapy. It does depend on your diagnosis, the size of the cancer, and the location, or more simply put, where in the pancreas it is. So please continue to share your experiences in the chat and any questions you might have in the Q&A. I strongly believe that keeping well is something that should be woven throughout your pathway and should be a priority for you and the healthcare professionals involved in your care. And that's from the point of diagnosis onwards. Spend a little more time now chatting over some things that I thought might be useful for you to think about, not just for before starting treatment, but for during and after treatment also. Wanted to have a think about what questions might be useful to ask your team when you're discussing treatment. Remember, clinic appointments are your time. Go with a list of questions. There are never any silly questions. And if you're worried about something or you do not understand something, ask. You don't always have to wait to be in clinic to ask questions. You can seek advice and support from your clinical nurse specialists. And of course, you can get in touch with us here at the charity. Our top 10 treatment questions are shown. I won't go through them, but give you time to have a look. And of course, you may have your own questions as well. Always remember, as I said before, no question is a silly question. And when we're thinking about keeping well on treatment, I think it's always so much more valuable to hear from people who have personal experience. So I'd like to share with you a short video clip from Claire and Bradley, where they share their experience and thoughts on chemotherapy treatment.
If things are going wrong, is not to be frightened if your doctor suggests getting the dose reduced. You know, we were terrified of that happening, and actually, you know, thinking back to those first 2 doses of FOLFIRINOX that you had, which absolutely trashed you, you had it reduced down to like 60%, and the difference was astonishing. And interestingly, the first routine scan you had after that still showed that it was having some effect. But it meant you didn't end up on the chemo ward with neutropenia for 2 weeks. Being prepared to have those discussions with your doctor and to take your doctor's advice is really important, isn't it? And I think that the key thing here, the theme, is about assumptions. So it's that assumption that it's only going to be a 100% dose of FOLFIRINOX that's going to work. And, you know, it was suggested to us after your 3rd bowel obstruction, whatever it was, that actually there's no way you could continue with FOLFIRINOX. It's just way too toxic for the bowel. And GemCat was suggested, which, you know, we were thrilled that there was another option, but we were advised this probably won't do anything. You had a year of that, and for 7 or 8 months of that, you know, the CA19 just came down, and, you know, you did really well on it. And so it's about not having that assumption that there's only one thing that's going to work.
Thanks to Claire and Bradley for being so open and honest about their experience with treatment. This is probably my top tip to you all too, with thanks to Chris, just to quote. It was about asking questions. So now a question for you. We'd love to know your thoughts on what you think is important when you're preparing for treatment. Something should come up on your screen now if you feel able to join in, and there's absolutely no pressure to. And remember, pop any questions you might have in the Q&A. I'll just leave that for a couple of seconds for you, give you a chance to be involved. Yeah, interesting. So all of the above. Many people do need to have thoughts on what is most important. Well, I'll look at this a little bit more detail now. Thank you very much for taking part. We have a couple more, so be prepared. So preparing for treatment. I know that waiting to see the oncology team to discuss treatment can feel like an anxious time. People often describe the feeling of just wanting to get started with treatment as quickly as possible. However, we know that taking some time preparing for treatment can really help you to be as well as you possibly can be before starting it. By taking time to focus on your well-being can help you to improve and maintain your quality of life, which may in turn help you to tolerate treatment better. Being seen by oncology in a timely manner is really important, of course, but use the time between appointments as an opportunity to work with healthcare professionals on tackling the symptoms of pancreatic cancer. Those symptoms might include things like indigestion, tummy pain, back pain, changes to your poo, weight loss, loss of appetite, feeling or being sick, fatigue, and that's just naming a few. There can be more. We know that focusing on diet and digestion is a priority for people with pancreatic cancer, coupled with exercise and emotional well-being, which has been proven to keep people well before, during, and after treatment. When we look at the subjects and those that you said in the poll, you know, diet, absolutely. A good balanced diet along with what you fancy, perhaps little and often, dietetic input and pancreatic enzyme replacement therapy, or PERT for short, such as Creon to help aid digestion, can all help. But predominantly it's having that support and advice as and when you need it. Exercise equally improves physical function, can reduce fatigue, it can enhance mood, and can help with cognitive function. And chemo brain symptoms do exist and are very real for many who undergo chemo. So memory lapses and difficulty concentrating, exercise may help with. But exercise isn't necessarily doing a marathon, but perhaps more a gentle walk, something that you can manage and not overdoing it. You have to listen to what your body's telling you. Emotional well-being. Emotional symptoms can affect you physically and vice versa. Your physical symptoms can affect you emotionally. Talking about how you're feeling can often be helpful, but not everyone finds this easy to do. Some people prefer to talk to someone they know. Others choose that they don't to speak with people they don't know. And it could be religious or spiritual leaders or peers who share a common experience. When managing symptoms, it's about seeking early intervention, good communication with your team about the symptoms you're experiencing, and taking medications as prescribed. And to cover everything in one way or another, they're likely to intertwine and all be important when preparing for treatment, but each person's preparation will be personal to you. So I want to share some thoughts on how to keep well on treatment. Before starting treatment, ask how will this treatment make you feel? There are common side effects with chemo, which we'll touch on in a moment, but you should be given written information on the proposed treatment, as we've mentioned previously. And you can also find detailed information on our website on treatments for pancreatic cancer. Ask how are the side effects prevented? Often the commonly experienced side effects will have preventative medications. You must take these as instructed, and if they don't help, tell someone. Manage symptoms of pancreatic cancer alongside any side effects that you might experience from the treatment. And if you're able to, keep a diary on how you're feeling. A diary is a great tool to help you and the healthcare professionals. You can look back and see any patterns of symptoms and side effects that you experience. Side effects need to be managed proactively. What do I mean by this? Often there are patterns to side effects. For example, your chemo may make you feel sick, but you have noticed that this is only on days 3 to 7 after the infusion. By keeping a diary on how you feel and a pattern emerging, I would then suggest taking an additional anti-sickness on days 3 to 7 to prevent the issue. Prevention is better than cure when it comes to side effects of treatment management. If you're still experiencing common side effects, even with increased management, let someone know. Discuss how you feel with your team at every review. Call your clinical nurse specialist to discuss any non-urgent worries or concerns you might have. And again, remember, there are no silly questions. If you're worried about a side effect, ask. Your team will be able to offer ways to manage side effects, but only if they understand exactly how you're feeling. We know that treatment can cause side effects. Some are common with chemotherapy and others are a little more specific to the individual drugs and treatment. So nausea and vomiting is a really common side effect of chemotherapy, and anti-sickness medications are often provided for during and after chemo days. If they're not working, it's important to let someone know and let them know early. Diarrhea and constipation is another common side effect of chemotherapy, but sometimes it's other medications, such as the anti-sickness tablets, that also affect the way your bowels work or not. So it's not unusual for your team to tweak, adjust, and change your medications to keep on top of the side effects. Low blood count. Chemotherapy attacks the cancer cells, but chemotherapy can't distinguish the good, healthy cells from the cancer cells. So a very common occurrence is low blood counts. Chemotherapy affects the bone marrow, and this is where the white cells and red cells are produced. When attending for pre-chemo bloods, your team may say you can't proceed with treatment. Sorry, God, I had total mind lapse then. This week, you've got a low blood count, but which ones are low? If you're not sure, please do ask. It might be the white cells and neutrophils that are low, and they're the ones that fight infection. Or perhaps it's your platelets, the ones that help you to clot, to heal a cut quickly, or your hemoglobin, the cells that carry oxygen around your body. The suggestion, if any of these are low, might be to have a week off treatment, and this is quite common to allow the bone marrow and bloods to recover, and that would recover naturally. If this is a regular occurrence with low blood counts, a dose reduction of chemotherapy may be suggested. It's a normal and safe way of managing the side effects of low blood counts to have a dose reduction. So, sore mouth and taste changes, very typical alongside a low blood count. The white cells that fight infection, if they're low due to chemotherapy, allows the normal bacteria in the mouth and digestive system to go a bit berserk. And this can show itself as a sore mouth, mouth ulcers, oral thrush, to name a few. Prevention is better than cure again. Mouthwashes are commonly used to prevent the ulcers, and if you have a strange taste in your mouth, go have a look inside. Have a look at the mouth and the tongue for signs of oral thrush. Any doubts, call the 24-hour chemotherapy hotline for advice. The next three are more specific to certain drugs, and I think I pressed it a little bit early before, so they're the last three. Tingling fingers and toes, cold sensitivity, sore hands and feet, and a reaction. At any time during treatment, if you feel unwell or feel not quite right, let someone know straight away. All of the potential side effects and how they are treated should be discussed and explained in detail by your oncology and chemotherapy team prior to you starting treatment. So, what helpers are available to keep you well with an incurable pancreatic cancer diagnosis before, during, and after treatment? Who's here? Pancreatic Cancer UK, of course. We can offer you support to help to keep you well with sessions like tonight. We have a wealth of information on our website too that you can utilise as and when you need. And of course, our support line services as well. And I'll tell you more about those shortly, a little bit further along. So then we've got palliative and supportive care, and they're two words describing the teams or services of care and support that are available to keep you as well as possible from the point of diagnosis onwards. You might already be aware of or have thought about some of the help available to you, and you might have had the opportunity to talk with your family, friends, nurse specialist and oncology team about these also. So how can you access palliative and supportive care? Local cancer support centres such as Maggie's, and they're a charity who have a number of centres dotted around the UK that tend to be on the sites of hospital grounds. They offer psychological support, complementary therapies, have support groups, and some have tumour disease specific support groups as well, along with financial advice. And there's lots more that I've only mentioned a few areas of support they offer. If there's not a centre near to you, then there's also online support for you and your loved ones. Another brilliant resource are the Macmillan Information Centres. They're usually found within the hospital where your oncology team are or where your chemotherapy is administered. They can provide information and support for you and your family from more of a local perspective, advising what's available in your area to keep you well. And that might be local support groups, such as walking and gardening groups, perhaps, and complementary therapies. There's likely much more that they can offer. Be worth a visit to see. And if it's on the site of the hospital that you attend, you could perhaps tie it in with a before or after pre-chemo bloods or clinic appointments. So the emotional, holistic and social support may well be best served by the teams and centres already spoken about. For the medical support side of things, to keep you well, that would be via your hospital team, which includes your clinical nurse specialists and dietitian, if you have access to one, and your GP practice, who might suggest and have access to district, community and Macmillan nurses, who can support and help you to keep well. Ooh. Last but by no means least, we've got the local hospice. Let me just have a look, lost my thing. When I discuss the hospice, people can often feel a little alarmed because I think we often initially associate the hospice with death and dying. And whilst the hospice does support people as they approach the end of their life, hospices these days, in my experience, are very much focused on supporting people to live as well as possible for as long as possible. And a key component of this is them offering proactive symptom control. And this can typically be done sometimes as an inpatient, as an outpatient, or in the community. So I've waffled on for quite a while now. So let's hear from Claire and Bradley, who are going to let us know their experience of accessing support.
So I think one thing that we
top tips
haven't mentioned that we should mention is about engaging with palliative and supportive care and not being frightened of that, understanding the difference between palliative care and end of life care, because they're quite different things. And I think if we hadn't engaged with a fantastic hospice, our life would have been much the poorer. wouldn't it? You know, thinking about,
Oh golly, yes.
you know, the complementary therapies, you know, the counselling that you've had. I've had some family support sessions. We had a community nurse that came to see us. She was brilliant. That the psychosocial and spiritual support that can help to keep you well, as long as the actual acute medical interventions. And I think it's both of those things that keep you bobbing along. So I would really encourage people, don't be afraid of engaging with that, because there's so much, it will enrich your life.
Best unmute myself, although you might prefer not hearing me. Thanks once again to Claire and Bradley for sharing their experiences. People can often feel anxious when treatment finishes, and there can be feelings of uncertainty about what happens next. I'm often asked, why can't I just carry on with treatment? It's a very reasonable and understandable question. Everybody is different, but it is common for people to have a break after they complete 6 months of treatment and be placed on something we call active surveillance. This is a period of time when you are not going backwards and forwards to hospital, and you can focus on recovering from treatment and hopefully have some normal-ish life. This for some might feel a little odd. After such a long time of frequent hospital visits and close observation, it can just feel strange. You should check with your team about what the follow-up is for you. It might be that this is a good time to ask about what happens next, what's the next treatment, might this include a clinical trial? And I think it's important to know that when treatment finishes, it doesn't mean the care and support ends. Often the care and support that will be most beneficial to you after treatment finishes isn't based at the hospital, but is based closer to your home, as we've touched on tonight. And when on active surveillance, keeping in contact with your team via the clinical nurse specialist is key. If there's anything that you're uncertain about, or if you have a new symptom, letting somebody know is really important. Getting you involved again, our next poll question. Thinking now about where or who would you talk to for advice on treatment if you can't have surgery, and where you might find tips on how to keep well before, during and after treatment. I'll just leave the poll up. Hopefully you can see that all and feel like participating. A high percentage doctors, nurses, so your hospital team perhaps, and Pancreatic Cancer UK or other organisations, perhaps Macmillan or one of those. And using Google and online, absolutely, it's at our fingertips, isn't it? And AI, it's an ever-emerging way of finding information out. We'll talk a little bit more about that, or I will, a little bit further on. But thank you so much for taking part in that. And if you answered other, I don't suppose you'd mind popping that in the chat, what you do. That would be really helpful. Thanks, for us to reflect back on. And perhaps, Simon, if there's anything you can comment in the chat. Anyway, we'll move on because we've got still a bit to cover. So thank you very much. So I wanted to share with you some of our support information that includes the support line, telephone number, an email address that comes straight through to the nursing team here at Pancreatic Cancer UK, our WhatsApp number and our website. As you know, Simon and I are 2 of the 7 specialist nurses on the support line during the time shown, and you can contact us in a way that suits you best. And that WhatsApp is probably really good if you're one of those people that wakes up in the middle of the night and think of something, you could jot it down and send it us, that or email. A really handy anytime way of contacting us. And there's also peer-to-peer support via our Circles groups on WhatsApp and Facebook. So, Circles is a way to connect with others going through or sharing a similar experience as you via WhatsApp and Facebook. It's for those living with pancreatic cancer and for those supporting their loved ones. There are different groups available, such as the 3 a.m. Club, as I've just mentioned, the Family, Friends and Carers group, and the Living with Pancreatic Cancer group. To give you an idea of the types of things discussed in the Living with Pancreatic Cancer group, some things have been mentioned, questions about different types of chemo, clinical trials, recipe ideas when you're on chemo, if you're feeling sick, etc. Techniques to help with waiting for scans, and that can be a period of time where you do wonder how to get through it as you wait for the scan results after having it. And then routines and planning. So some really helpful peer-to-peer support potentially. And a couple of quotes we've captured from those using circles and other feedback we've received includes that it's been an invaluable support, and not only for information sharing, but also to follow experiences of others to help with managing symptoms, things to ask, what to expect, etc. It's a reminder as well, circles, that there are common shared experiences, so you're not alone, even though it can feel at times like you are. And the emotional support and practical information, not necessarily medical, has been invaluable. And they hope whoever completed this had also been of help to others too. So, some take-home tips, which I'll leave you to have a read through, because you must have had enough of hearing about me, and I've still got a few slides to go. So, one thing that I will pick out is to check any information that you find on the internet or through social media with a health professional. I can't stress enough, there is so much information on the internet, and of course with AI and Dr. Google, it's always worth contacting a health professional to go through what you found, whether it's applicable and whether it's appropriate. Just my tip from me to you. So before the Q&A, our last poll, and hopefully you're not too sick of my voice and feel able to continue taking part in the poll. It'd be great to know how confident you now might feel after tonight's session with talking to your team and family about your treatment plan. Oh, that's good. So some are feeling confident and very confident, somewhat confident, and there are a few that are not confident. I can't stress it, enough that if there's anything through from tonight's webinar, if you wanted to call the support line, talk through things on a more personal basis, because this has been a general overview. So, please, by all means, give us a call and hopefully we can increase that confidence for you. Okay. Thanks so much for joining us tonight. We hope you found it helpful. We're not going yet because it's now time for the Q&A. So although I've said thanks for joining us, please do stay. Simon and I will be delighted to answer your questions.
Okay. Sorry, momentarily distracted there because I've been trying to answer some questions as we've gone along because there've been a few. Thanks, Lee. That was brilliant. It's so much information to get through, but delivered really clearly. So thank you for that.
Thanks.
I will now open the Q&A box, and we'll have a look at the ones that I haven't covered. There's been quite a lot in the chat, which is why I'm probably look a little bit distracted. And people have been talking about all sorts of other treatments like dendritic cell therapy has come up a couple of times. So I thought we should perhaps start with why we haven't covered that in here. And one of the reasons for that is because it's not a standard treatment that's available in the UK. It's not available on trial either.
Yeah.
So it's a private treatment that you would have to go to Germany, I think, for. So that's one of the reasons we haven't covered it. There are other treatments out there that you can access privately, but we've kind of stuck to the standard treatments because that's what you can access here in the UK currently.
That's right. Yeah.
I don't know any more thoughts on that, Lee.
No, I think because it's not a treatment that we are able to offer here in the UK, I think absolutely if it's something you'd like to know more about or we can help have a chat with you about, it really is important to call the support line so that we can take a more personalised approach to your situation. Yeah, I agree with what you said, Sam.
I think that's the other thing. It's trying to answer questions sometimes which are quite personal, and we can do that in far more detail on the support line. And the support line can be email or WhatsApp. So if you want a specific question, you don't particularly want to talk because that can be hard. Sometimes it's not always easy to chat to somebody on the phone. So feel free to pop your questions in email form or, like I said, WhatsApp if that suits you better. Okay, so let's have a look. Questions. One of the questions was could chemo be used for pain? Just thought it was an interesting one.
Yeah, chemotherapy might help with pain and discomfort because if the chemotherapy can cause a shrinkage of the tumor, it may help with any pain that you're experiencing. It's not guaranteed, but if there is shrinkage or a stability or what's the word I'm looking for? A positive outcome from the chemotherapy, it may help with symptoms, and one of those symptoms might be pain.
Great, thank you. And a specific one from Sean, he's asking, it's just dry cough at night, and is this related to chemotherapy? Which I guess is a tricky question because it could be related to lots of things,
Mm.
particularly in a hot spell. But
Oh,
I think we can answer that in broad terms, can't we?
and all the pollen as well that's around at the
Yeah,
moment. Depends on the chemo treatment that you're on. And it would be something I would definitely encourage you mentioning to your oncologist, your team. And if it's causing you problems like you can't sleep because you're coughing at night, could also be down to something like acid reflux. So if when you're lying down, you may have acid reflux, so it might not be chemo. Um, it's worth speaking to your team because I would presume that whilst you're on chemotherapy, you'd be on a proton pump inhibitor, PPI, which helps with acid reflux. And if that is contributing, yeah, it's definitely one to ask your team about because I don't know enough about, sorry, Sean, what your regime is or where you are in treatment. And yeah, something to talk to your team about. Or, call your nurse specialist if you want to, if you can get a quicker answer before seeing the team.
great, thanks, Lee. Um, there have been a couple of related questions from people around stage 4 pancreatic cancer
Hmm.
and surgery. So having treatment, chemotherapy treatment, and responding well, and whether that would mean that surgery would then be possible.
Hmm.
So I've been trying to answer a few as we've gone along, but it's come up a few times. So I thought we should cover that question. And sadly, my response to that was that if you have stage 4 disease, then automatically that means surgery is not an option for you because the
Yeah,
disease has already spread beyond the pancreas, and that's regardless of how well you respond to treatment. Don't know if you have anything more to add to that, please.
no, it's not amenable usually to surgery if it's a stage 4 diagnosis because, as you say, it's spread from the primary pancreas and to other organs such as lungs and liver. Or elsewhere, lining of the tummy, which means that it wouldn't be, you need to have systemic therapy, which means it's everywhere, like I mentioned before, rather than a treatment that will help to remove the cancer. Obviously, people want surgery, but a stage 4 diagnosis is not amenable to surgery. But you know that for people that have got locally advanced or borderline resectable, so stage 2, stage 3 cancer, there are sometimes episodes where chemotherapy can shrink the tumor to make surgery amenable. However, with stage 4, in my experience, that's not being an option.
Yeah, and that would be my experience as well. But as with all these things, it's go back to your treating team if you're having questions
Absolutely.
like this,
Yeah.
to speak to your oncologist and your CNS.
Yeah.
But certainly in our experience, that's not something that's possible.
No.
Um, okay, we've had a question around support available to the person and their family around, sadly, I suppose what a lot of people struggle with is the financial aspect of being diagnosed with a disease like this,
Mm.
and not being able to work.
Mm-hmm.
So, and this question is specifically around housing.
Mm.
So I guess there are going to your local housing association will be start one, I guess, for that. But also, if you can have contact with your CNS in the hospital to let them know of your potential, your personal situation. Palliative care teams can also be helpful because sometimes they'll have people like social workers who work within the team that can help. Anything
And
from your perspective?
yeah, Maggie's centres,
Abby's, yeah,
the Macmillan centres, although financial advice and support perhaps is a little limited with Macmillan centres currently, but Maggie's for sure, they have that, even if it's not in person at a centre, you can go online and they may be able to do a video call or put you in contact with somebody that can give you financial advice. We did a webinar recently, didn't we, about
yeah,
financial support.
we
It would
did.
be really useful to have a look at that because another thing I thought of as well was before I forget about it because my memory's not the best, Citizens Advice Bureau as well. So there'll be one local to you for help with rent support, etc., with a cancer diagnosis. Um, and also they may be able to help you alongside with the Maggie's team to look at benefits and other things that you might be entitled to if you're not working, depending on your age. And so, absolutely, I think it's really worth getting in contact with Maggie's, Citizen Advice. Yeah,
Yeah,
and
I
as
was
you
going to
alluded
say
to,
citizens' advice sometimes get forgotten about, but they're a
they
great
do. Yeah,
resource. And when you're looking at PIP and the different benefits that are available, it's really complicated. So getting help
mm,
and advice, I would say, is crucial because you need to know what to apply for and what not to apply for.
yeah,
So you need
yeah.
somebody to understand your situation, specifically your situation, to then guide you through what to do and how to go about it.
And sometimes benefits can be rushed through depending on the situation. So hence why it's really, really important to go and see and speak to somebody if you can.
Yeah. I think also the stage of your disease can
Mm,
open up the higher rate benefits for you automatically because of the stage of disease. But you need to discuss that with either a doctor or a nurse because they'd have to complete paperwork for you.
yeah.
Okay. Question from Deborah about do we have information on hyperbaric oxygen therapy? I guess the short answer is no. It's one of those therapies we are aware of, and people do ask us about it, but it's not something. It's not something we have information on the PC UK website, unless it's snuck in there without me knowing. Um, yeah, so sorry, Deborah. No, we don't. There are lots of treat. Vitamin C would be another one which is brought to our attention that
Oh,
people are
yeah.
into, but it's not. These are non-standard treatments, and finding the data to back up the use of them is where we have to be able to present things with.
Yeah, and it's also considering the where you are in treatment, whether it's appropriate, something to ask your oncology team about
Yeah,
for sure, because it could be a complementary therapy perhaps. But yeah, as Simon says, not something that we have great knowledge about, but we know that it's there.
yeah. I think it's always worth asking questions when it's to look at your overall benefit in terms of quality of life as well
Yeah,
as the treatment that you're having.
yeah.
Okay, how are we doing for time? We're doing okay. Um, sorry, it's a long question. Um, okay, so it's a question around supporting somebody with pancreatic cancer who's not yet got a staging. It's like several stent procedures and infections that cause complications, which is delayed chemotherapy,
Mm,
cancer close to the main artery. So it sounds like some confusion maybe around the treatment plans and what the chemotherapy is for, and
mm,
whether it will shrink the tumour. I'm wondering if this is a question around shrink the tumour enough for surgery. I would say that's a question to go back to your CNS and your treating team exactly what they think is possible and what the
yeah.
treatment is for. It feels like there's a little some clarity missing maybe.
Yeah, and it does depend upon the involvement of the artery. So sometimes if chemotherapy does shrink it, and surgery is offered, sometimes they can peel cancer away from major blood vessels, which sounds awful because you think, well, you're not peeling a banana, but it literally is like that sometimes. But it depends on the involvement prior to starting chemotherapy as to the likelihood that chemotherapy is going to get the results that you're hoping for. That's why they intertwine it with chemotherapy in the palliative setting, because they can't be sure that surgery will be possible. And then with the mindset that they'll keep an eye on things, review after 3 months of treatment, I would presume, because that's typical, as long as you can tolerate 3 months, and then see where you're at and what the tumor is doing, and the vessel involvement. So it can be confusing because there's no clear guidance, because it's not surgery up front, but it's chemotherapy that may provide surgery at a later time point, but it's not guaranteed.
Great, thank you, Lee. And a question around what options are there on the NHS for metastatic pancreatic cancer with secondaries in the liver? And are there better options if you have insurance? Okay.
Good question. So, there's loads of information on our website. I'm not sure how we're doing for time, about the treatments for metastatic pancreatic cancer. It depends on whether you've had treatment already. And so it's really important to get a clearer, bigger picture. So this is probably one of the questions that, rather than getting into the nitty gritty here and now, be my advice to give us a call on the support line and we can talk about it. I've never personally worked in the private sector, so I presume when you're saying having insurance, you're asking about treatments in the private sector. I haven't worked in like I say, in that sector, so I don't know what they offer, but I can't imagine that it would be much different to the NHS. But it's whether that treatment, whether you've got insurance, as in an actual pay policy, or whether you'd be paying up front. But that is something completely different and not something that I have any experience in.
Yeah, I suppose, like you said, the trials are complex, aren't they? It's not something we can go into now because it does depend on so many different factors that it's probably best if that's something we can help you with personally rather than try and unpick it here. Okay, well, we've got 5 minutes. We've got quite a few questions here, which we're not going to get through all of them. So I'm just having a quick through. Let's carry on from the top. So, can you tell some side effects of pre-chemo steroids?
Yes. So if it's given intravenously, it can give you a feeling, and I presume this is what you're asking about, what side effects are experienced. Sometimes it can give you a bit of a rush feeling. It can make you feel, for some people, like you're wetting yourself if it's been given too quickly. Steroids can, if they're given too late in the afternoon, can keep you awake all night. They can increase your appetite. Anything else, Simon?
No, I think the thing with steroids is, I guess
It's
it's
anti-sickness.
when they're given for.
Yeah, and
If
they're
it's a
important.
Yeah,
Yeah,
if it's a short blast treatment, that's different from a longer term treatment. So I guess that's the um, mood swings. Yes,
oh yeah,
definitely.
forgot that.
Sean's just added that in. Yes, you can. There can
Yeah,
be there can be those kind of side effects with steroids. You can be quite a little bit hyper, a little
yeah,
bit perhaps agitated.
yeah,
Um, yeah. So
yeah,
it could, if it ties in with the timing of the steroid, Sean, then yes, it could be.
yeah,
And that's worth noting, just in case you have steroids later on, that you feel that that's a possible side effect. I would definitely let the health professionals know about that one.
yeah,
But mood swings could also be part of the cancer,
yeah.
and what you're going through. I guess it's a complex thing. Um, Okay. And what would be the criteria for nanoknife procedure after having chemotherapy? I guess that's
We
quite
were talking about that, weren't we?
we were, yes. So 3 to 6 months of chemo, and then it's a conversation with your oncology team about whether they feel nanoknife is appropriate for you, I guess would be my
So,
suggestion.
yeah, nanoknife is also called IRE or irreversible electroporation. It's a treatment that uses electrical currents to damage and destroy cancer cells, but it does depend, and this is really key, on how big the tumor is, what treatments you've had so far. If you've got any heart problems, you need to have a general anaesthetic. There are lots of things, and there's limited availability. There's not much research, and nice for pancreatic cancer in particular. This sort of treatment should only be used in research. That's their suggestion. It's well worth, as Simon said, speaking to the team about it. And it is sometimes used off-label, but I don't know much more about that. And it's not available in as many places as you perhaps think. But you can have a look on our website. There's more details about it. But that, in a nutshell, is my thoughts on it.
Yeah, it's not something we tend to come across often with people on the support line either, having had
No,
it. So we don't really even have an anecdotal sort of answer to that. So
no.
okay, I guess this is probably a question that is better answered individually as well from Sarah McCall, who's asking what does end of life look like with pancreatic cancer and what options are there? It can look like lots of different things, Sarah, is the honest answer, because it depends on so many variables in terms of how quickly or how not, or how relatively slowly it will happen. What you'll experience and why varies dramatically. What options are there? I'm assuming you mean perhaps care or support there. That's what I'll go with. If you're talking about end of life care and you need support, then that will be through a palliative care team alongside the team that have supported you with treatment. But often, if you've come to the end of treatment, then those teams will move back a little bit and hand care over, particularly if you're at home in community, to your GP, your community nurse, and a palliative care team if needed. So it's about reaching out to for support if you feel you do need that. And if you don't have a palliative care team involved, your GP and your district nurse would be able to refer you. And as with a lot of things in pancreatic cancer, because we know things can change and move quickly, if you're feeling you need help, now's the time to ask for it. But if you've got specifics, Sarah, around that question, I'd encourage you to give us a call, because that's the kind of thing we can help you with and talk through about your particular situation. Okay. So, question around the benefit of palliative chemo and what does it mean? So, I guess we've covered that in the session around that Lee's delivered. Is there anything else you want to add to that, Lee? Or
Palliative chemo can try and keep a control of the cancer. So it could provide an extension to life for some, but it comes with toxicities usually. So it's about quality of life. And so palliative chemo may provide symptom relief, but at the same time, it depends on yeah, I think that's pretty much a sum up of what palliative chemo in my mind is. And it's to try and keep a control of the cancer, to stop it going berserk, as we know it can do, to provide a little bit extra time.
thanks, Lee. Right, we've come up to 7 o'clock now. We can go a little bit longer. When should you be aware of the stage of the cancer? I would hope fairly early on in this process, because the stage of the cancer is key in terms of what happens next. So if you're not aware of the stage of the cancer and you're progressing, certainly if you're having treatment, then it's a question perhaps to go back to the team with, if that's what you're wanting to know, because yeah, it's key to what happens next, I guess. Okay. There's a message from Helen who said that she has stage 4 cancer but had surgery and has had 10 rounds of chemo, and it's a year since, and she's still here, which is fantastic news.
Absolutely. I echo Rachel's comment. That's amazing.
It is amazing. Um, I'm not sure if you mean you have stage 4 now, Helen, despite having surgery, or whether that comment is that you had stage 4 and had surgery. I guess that would be the. But fantastic that you're still here, and thank you for joining us.
Yeah, and sharing.
Okay, is SABR, so SABR, radiotherapy better than local radiotherapy? My husband has pancreatic cancer in the head, and a butt in the artery, and has been told inoperable, but the tumour is very small. Okay.
Want to ask the team about, because the radiotherapy specialists will, if your husband is referred through to their multidisciplinary team meeting, they'll have a look at your husband's case. I'll take it as your husband, yeah. So I think most definitely SABR is much quicker, as in you have less sessions, so it's like every other day over 2 weeks, but not including the weekend, whereas normal radiotherapy, or as you call it, local radiotherapy, it's done every day over 5 days, and you have it for much longer period of time. The way in which they deliver the radiotherapy is completely down to the size, the location, as I mentioned before, and whether appropriate or not for that treatment type. But it's a question, most certainly, is radiotherapy an option? It does depend upon also treatments already received. So for sure, want to ask the oncologist. I feel like I've said that a lot tonight, but they are the key people, because and you've heard me say throughout the whole evening, no question is a silly question. And it's about having the answers to the questions that are so dear and important to you.
Absolutely, absolutely. I would echo that. If you have a question, ask it. Okay. There's a question. I'll answer this one briefly. A question on news on Daraxon tablets in the UK. Just sort of referring back to the start of the session. The simple answer is no. Right now, it's not. As far as we are aware, it's not available, and we don't know when or if it will be available in the UK, either by the NHS or privately. But these things can change. So but we're talking in terms of what we know as it stands right now. It's not something you can access. Okay, I'm just going to jump to this question at the end, given the time, because I think it's an interesting one to look at. And the question is from John Yedden: should close relatives be tested? We have quite a lot of information on the website, John, around inheritance or the risk of inherited pancreatic cancer. I guess a quick answer is we sort of work on between 5 to 10% of cancers being inherited. So that's germline, if we go back to what we said at the start, whereas most of them are somatic. So most cancers develop over the course of your life and are due to things like lifestyle or environmental factors rather than being inherited. The question around whether you should be tested is quite complicated because it depends on your wider family history. If you have pancreatic cancer in the family and it runs from generation to generation, particularly if it's on the same side, so if it was grandmother, mother, same side, then you should go to your GP or speak to the team around testing, because you've got a generational, potentially generational movement there. But it's possible to have several people with pancreatic cancer in the family and there be no genetic link. You can have other cancers in the family, and I think Miranda has mentioned the BRCA gene. So if you know that somebody has a BRCA gene and then you develop pancreatic cancer, then if your team aren't aware of it, you should definitely let them know. But it's a question that's quite specific, John, I guess, in terms of your family history. So that might be one have a look on the website, and by all means give us a ring, and we can try and help you work through what that might mean for you and where you go. But at the moment, if it's genetic testing, it's through your GP or speak to your team at the hospital. Is there anything else from you, Lee?
No, I think that's good.
It's a tricky one, isn't it?
Yeah.
It's a tricky one. Okay. I think one last question: should you always get a second opinion? That's a tricky one to answer, I guess, because it's situation dependent. I would say, Lee, would you, in terms of whether you do or
Yeah.
you don't?
And a second opinion is something absolutely that you can ask for, and that can be via your team or the GP. But a second opinion does not always mean you'll have a difference of opinion. But it may give you the reassurance, if you did want a second opinion and got one, that if it is matching the opinion of the first team, that you may have reassurance that actually, yeah, what they say is what somebody else says as well. The second opinion is usually not to do with your team or a very close local hospital, perhaps, but something that, yeah, you can ask for. And it will not affect any of the care that you receive with your current team. I think that's really important to say.
Yeah. Right. I think we've covered all the questions. Thank you everyone for joining us, and thank you for being so engaged in the chat and the Q&A. There were probably things on the chat that we've not got to answer, so apologies there. But just to reiterate that you can come back to us on the support line. That's WhatsApp, on the phone, or email. So if you've left with something that you're not sure about and you don't know what to do, get in touch and we'll do what we can to support you. Okay, right. It's 7:10. So
good night and enjoy your evenings.
thank you
Yeah.
very much, Lee, for a great session, and good night to
Thank
everybody.
you.